Hi, everybody. Welcome back. It's great to have you joining us again. This is our final session together, and we are really hoping to set the stage for your next steps as you work to implement some of the resources and ideas that we've been discussing with you for the last few weeks. Certainly want to invite you to consider sharing your professional contacts with each other as a way to continue to support one another in your care settings. And as questions are coming up around building these resources out for your particular population that you're serving, that you can kind of lean into each other's expertise more and more. So we're getting a good amount of folks joining, and just want to be mindful that, sometimes meetings are running over and folks are joining a little bit after the hour. So we'll just give a couple more seconds, and then actually we can go to the next slide. And as we're discussing the next slide, just allow folks a little more time to join us. So again, this is an effort across the 14 National Training and Technical Assistance Partners, or the NTAPs. We have formed this Special and Vulnerable Populations Diabetes Task Force to really kind of collaborate and consolidate our expertise in our particular populations to disseminate knowledge and provide better engagement with the health centers that we are serving. We're also involved with the primary care associations and the health center controlled networks to really amplify that knowledge and reach to create, strategies and help impact how you're caring for individuals addressing their diabetes diagnosis. And our expertise really here is focusing on individuals experiencing homelessness, residents of public housing, and migratory and seasonal agricultural workers, school-age children, older adults, Asian Americans, Native Hawaiian and Pacific Islanders, LGBTQIA+ individuals, as well as our other health center patients. So just to kind of give you an idea of our task force and those of us at NTAPs that make up that task force. So you've joined us for a 4-session learning collaborative. Again, today is our final day together, and we'll do a little bit of a recap as well as talk about next steps for implementing this work into your care settings. And just want to remind everybody that we do have a learning series, this task force learning series website. So please feel free to visit the website. There's a lot more, there are many more resources available to you there, as well as a recap of the work that's been done with us. We can go to the next slide. So here we have just a little bit of a representation of those NTAPs I just mentioned. You can see all of our logos. Obviously, we span a lot of interests with special and vulnerable populations. And today we're, wrapping up this learning collaborative that's consolidating the efforts of the National Nurse-Led Care Consortium. I'm going to have to put on my glasses to read, the Farm Worker Justice Group, and the National Healthcare for the Homeless Council. Okay, so that's who's really represented here. But, please, you're invited to really explore the other resources that these other NTAPs are involved in. And just know that when you see work coming out of these NTAPs, it's quality work. It's specifically directed towards the needs of health center, community health center staff, and the patients that you serve. Okay, next slide, please. And then here we are. Here we are, your faculty and the individuals that are supporting this effort behind the scenes. Next slide. And then, just again, to bring your attention back to our website, if you have any questions about additional training or more consultation work that we can provide you, please feel free to use this email address. All of the NTAPs are funded really to support the work that you're doing in your community health center settings. So we are your access to these resources. So please feel free to use these resources and to utilize us in whatever capacity you think would be helpful for you when addressing the continuum of care for diabetes treatment. Next slide. Just an overview of our series objectives. We were able to address and touch on implicit bias, as well as cultural humility as a facilitator for engaging patients in diabetes care. Also looking at strategies to engage patients in their treatment, but also in developing resources for diabetes care. And next slide. And I'll just pass it over to Darlene, who will walk us through a little bit of an overview of that second session.
Great. Thank you so much, Jillian. And good morning or afternoon to everyone. Just as a refresher, when we talked about implicit bias, just a little, I guess, definition that we all can kind of recognize when we hear the term implicit bias. It's known also as a social bias where we are unconscious of having attitudes or stereotypes about different people. It could range from race, gender, age, geography, sexuality, and it's really in an activity that it's involuntary. And so a lot of times we may be looking at a person, and I think where we wanted to make sure that we were getting the point across when we're talking about patient-centered resources, even developing patient resources or giving individuals, your client or patient, materials, that we do not let our implicit bias, our unconscious bias, be a barrier as far as what we're sharing with them, what we think that they will understand. And so we just really want to make sure that we're in tune to some of our thoughts and some of the ways that we are delivering the information. And one of the ways that can be a safeguard against implicit bias is the exercise of cultural humility. And that is again when we recognize that we are the learner and the client is the teacher, and that they are the best ones to inform us on what they're feeling and what they need. And that was one of the reasons why I wanted to have Art and Dee Dee come and share their experiences, because it's very good to hear a lot of times from clients and patients just what matters to them and how they want to really be part of the conversation. They want to have the conversations with their healthcare provider. Many times what they want to focus on may not be our plan. And so starting where they are and then moving them along the continuum of getting to where they need to be or where we would like them to be is part of exercising that cultural humility. So I think that's all. If there are any questions regarding implicit bias or cultural humility, I'll be happy to answer at this time, or you can share any question that you may have in the chat. And at this time, I'll pass it back to Jillian, and she's going to kind of do an overview of the other sessions that we had.
Thank you, Darlene. Yes, if you have any questions, feel free to raise your hand with one of your, I think it's a reactions icon that you can use, and we can invite you to share your questions, certainly add them into the chat and we can address them ongoingly or towards the end. But just to follow Darlene's explanation, one of the areas that we touched on in session 3 was an agenda setting tool that is provided from AHRQ. So, kind of thinking about resources that can help facilitate that patient engagement in the patient encounter or in the care setting, where we can ask, as Darlene was pointing out, the expert in their own life, what's important to them, what are the needs that they have that they'd like to address with a trusted healthcare professional. So just to remind folks that these are all publicly available. So can review some of those slides or some of those subjects that we talked about in session 3. We did also discuss bridging the digital divide and beginning to understand within the population that you serve, what are the ways in which we can attempt to support individuals becoming more digitally literate, being able to navigate through our patient-facing technology that we're hoping to engage them in, and then how to ask and invite our community into the conversation when we're in those development phases. They can provide necessary perspective on, is this going to work within this population? Do we have the appropriate access or bandwidth to use these sort of patient-facing technologies? And then we also delved into what is it to create a language access plan, which many of you shared you've already been exposed to and have in development. And some of you were in different stages and phases of that. So, understanding that this is a priority and an area to lean into each other's peer expertise, reach out, understand, how you might be utilizing it in your care settings and where there might be room for improvement. And then always thinking to test these out with your patient feedback and being mindful that they are in this as partners, certainly leaders in their own wellness care planning, and are essential resources for being successful in how your technology and your resources are utilized in the care setting. So those are just a little bit of an overview, and we can go to the next slide. So moving into Mentimeter, those of you that have been with us this whole time are familiar with this. We're going to launch our Mentimeter opportunity. You can open this in your cell phone or in another web browser. And we will be using menti.com to access our Mentimeter experience. And then the code has been shared here by Sabrina. Thank you. And it's 1653 1932, and that code is at the top. And the question here is, what are your key takeaways from this learning collaborative? Were there spaces of increased knowledge gained for you in the area of role of implicit bias, strategies for patient engagement, bridging the digital divide, or creating a language access plan? Feel free to select the key takeaway for you. And then these will begin to populate on the screen for folks to be able to see. If there seems to be areas beyond these 4 that you'd like to identify as well, please feel free to share those in the chat or unmute yourself to discuss or highlight other things that may have come up for you as potential takeaways or little nuggets that you might like to share with the other folks in this learning collaborative. I love always, sharing strategies for patient engagement, patient and family and community engagement. I think there's endless opportunity to learn more there. All of them. It's great. And thank you for those of you who are sharing your responses. Wendy's sharing the appreciation of encouragement to include to partner with a patient panel for their input. And it can really feel like a big undertaking to have that creation of the patient panel. It's really invaluable. Obviously, there's certain expectations that communities are involved in the community health center space, but how to involve them. So I think it can be really helpful to identify concrete ways in which we want to engage our patients and our communities in our care, our healthcare settings. And certainly this is really a great concrete way, understanding how to use their perspectives and how to invite their perspectives into the development of resources. So we can go on to the next slide. Thank you, everybody, for sharing in the chat and sharing with Mentimeter. So I'm going to pass this over. Alexis has this amazing story about how the patient, the community, and family engagement helped to clarify and develop a resource that was developed at Farm Workers Justice. And isn't this just amazing? I love comic books anyway, but what an inviting resource to share in the healthcare, in the health center space.
Thank you, Jillian, and apologies for my voice. Hopefully you can all hear me. So kind of illustrating the example of patient-centered resources and how do we engage our communities and the resources we develop. I wanted to share this resource that Farm Worker Justice developed about 4 years ago. And when we were developing this resource, we worked with a community partner, and we worked with also an artist in Mexico. And when we were talking about diabetes with our community partner, what many of them talked about was that for many of farm workers in their communities, that diabetes was kind of seen as a death sentence. And that when they thought about diabetes, they thought about all the things they couldn't do and all the things that they couldn't eat. And so we, talking with our community partner, we wanted to kind of create this more positive spin and really emphasize the fact that, you may have diabetes, but it doesn't mean that you can't be involved in family gatherings and that you can't still be a part of these celebrations, because that was a concern that we heard from our community partners. So we know that comic books are, at least for farm worker communities, are a great tool because many farm workers tend to be more low literacy. And comic books are a great way to illustrate a story using both images and words. And so this comic book, which is also available in Spanish and Haitian Creole, what it does is it basically focuses on a farm worker, and then he kind of goes through. He's taken to a store, shown kind of how to look at foods, but also shown that, hey, just because you have diabetes doesn't mean you can't be a part of these celebrations, and you can still eat some of the foods that you've always eaten. And so as we were developing this, after we developed a rough draft, we went to our community partner in Florida, who serve both Haitian workers and Spanish-speaking workers. And we asked them to share the comic book with them. We got their feedback, and then we incorporated their feedback into this final version. So hopefully, we've gotten good feedback since then. Of course, it can always be improved. So I guess the question for all of you is, looking at this resource, what are your thoughts? And what are your reactions? And based on kind of how we talked about how we created this resource, how have you done the same, creating your own diabetes resources? So I'd love just to have just a short discussion with all of you about it. And please, feel free to criticize it. Totally fine. It's there's always room for improvement. So you won't hurt my feelings.
And just to piggyback on that, not only take this as an opportunity to look at this and see, the influence of the community in the representation here in this resource, but can you imagine something that you might already be using in your community health center setting and how you might be able to see where the influence or the input from your community might make a difference in how that resource is presented. So certainly asking those of you who are feeling like you'd like to share, you know, how do you feel, or what do you see here? And what can you imagine that you might be able to focus on with the resources that you have back in your care settings? And feel free to just jump off mute and chime in.
Yeah, I think so, Wendy, what you say about community input, you know, so at Farm Worker Justice, you know, we are not a health-centered organization, but we do a lot of health promotion projects. And we really rely, because we're a national organization, we rely very heavily on our community partners who have that connection with the farm workers in order to make sure that all of our materials are appropriate for them, and are delivered in ways that are accessible. And I think in terms of, you know, the digital mode, you know, we've been doing more of that recently. We have been doing more like PSAs. We recently did, not diabetes related, but we recently created a children's vaccination song around COVID with a video. And so we're trying to think of like other ways that we can provide information to farm workers, but the farm workers, the community partners are always at the center, because we want to make sure that all the work that we do is something that is that will be receptive for the farm worker communities that we serve.
And just to follow up on that, you know, when you're considering these patient-facing technologies, there are many, and the most obvious, you know, is the patient portal. That's a place that a lot of community health centers have been trying to create more usefulness, more utility. You know, they're not necessarily as utilized in some settings as in others. And so I think that's where, you know, there's a want for our communities to use these technologies more. The question is, why aren't they? And that, you know, obviously is where the influence and the input from the community can make a difference. But it might be that there's something about the interfacing with that patient portal that just isn't accessible. So, you know, can we use visuals to help bridge that gap a little bit? Would it make more sense, instead of having things heavy language based, that it could be more visual based, so that after a little bit of training, a person will understand how to navigate, you know, from one place to the next within that patient portal, how to use images and icons as opposed to the language. And another space is with secure texting. Some populations are not utilizing cell phones to the same degree that others, but perhaps secure texting is one way to support folks that might be in maybe a diabetes prevention program, or they are having a case manager that's working with them, who can send secure texting back and forth for reminders, for tips, quick links to videos to watch, that kind of thing. So I know that we didn't like dive deeply into the actual tools themselves. There are a lot of tools out there, but I think coming up with the plan of which ones you're going to use really must be informed by the population that you're serving. Not must be, but it's very helpful to kind of lean into that when you're trying to craft your technology platform a little bit more, how you're going to interface with patients. And it may be that actually technology is not the answer, that it's really using paper still, or using something like a comic book, you know, to share the information. So just some thoughts there. And thank you for that. Thank you for that feedback, Wendy.
May I, I'm off mute now. May I ask, may I say just a couple more things regarding that? Okay. Oh, perfect. Thank you. I really do appreciate the comic book format. That's really cool, and wish that there were more, or if you can point us to where we could actually access more of that type of thing. But I'm looking for specifically to the diabetes patient. I mean, this is good because this is about the nutrition piece. This addresses that, but we also have the need for presenting information, potentially. I mean, it's really multifaceted with looking at the different areas of diabetes education, to have a well-informed patient to manage their diabetes well. And so when I was able to develop like a flip book for the hospital side on survival skills, diabetes survival skills, but it was really and kind of framed as diabetes education to go, just the most essential information that a patient with diabetes needs when they leave the hospital. And it was thought by my manager on the ambulatory side that something like that would be really nice also in our setting, in the ambulatory setting. But we're working remotely now, so that's the challenge. How do we best present those essentials, which then the diabetes educators, the CDEs, can actually build upon and expand upon. But we don't have time when we're doing complex case management to do, the degree and take the time that is required that the diabetes educators can. But we can reinforce and we can build on, the basics. And that's what, I was kind of looking for some direction to get some of that if it's already been developed, or if not, then that's something that we need to work on, considering the great points that you've made with these collaboratives over the weeks.
Yeah, I think so, there are some resources, but and I know a lot of, especially farm worker focused organizations, do a lot of fotonovelas and comic books because those are kind of the widely known and widely accepted forms of health education. But one thing to think about because we're going to talk next about an action plan is, I don't know if the population you serve at your health center or in your community, if they are, if this would resonate with them. And so we're going to talk about action plan. And so maybe, the action plan could be, maybe thinking about what kind of resource would be helpful, and who are the community partners. So we rely, as I said, very heavily on our community partners, sometimes a little too heavily, because sometimes I think they are a little overwhelmed. But they always are there to work with us, because we've created that relationship. And having those community partners, I think, are really essential. Everyone has different ends in the community, and everyone has different touch points in the community and different familiarities with the community. So I think being able to kind of, create a space, even virtually, where you can connect with the community organizations, I think is a really important starting.
Well, I mean, we're an FQHC, so we serve the underserved. I mean, for sure, we've got all that was described and more, with mental illness, with substance abuse, with the low literacy. And I really feel like our organization has not, they don't really address to the degree that I'd like to see, especially the health literacy part. A lot of the materials are not geared to like a 4th to 5th grade level, and instead some of them they're trying to put out are like college level. And that's just for written materials I'm speaking of. And so Yeah, we've got a ways to go. I'm on the education committee, and have tried to make a pitch over the years to, try to remember this, but sometimes materials get snuck through and it's challenging.
I can imagine that it probably is very challenging, and this is not unusual, Wendy. So this is what we all deal with. But I'm just wondering, who decides what resources? Who decides what will be produced, what is needed? So I think that decision of what is needed really starts the question of then who needs to be at the table to produce it. And so if we talk about, okay, we're going to do something on diabetes, okay, and who said this is important, and have we talked to what is already available, what are the gaps, and who do we need to talk to that really helps us to fill the gap that we've identified. So a lot of times, we'll come up with ideas. Oh, we need to do this and other, because we do it all the time. We need to do this. Well, who said that? Okay, and have we talked to anyone outside of our own, internal conversations? And how do we really find out what is needed and who should be part of the conversations to inform that? So just using my own, experience when I was developing the diabetes, with the COVID, I said, oh, we need to do this. And I sent it out to Art and Dee Dee and some of the other clients. And they were like, yeah, this is good, but yeah, no, you need to change this. And I totally came from a whole different, angle that they wanted to take it. And so it really is important to have that conversation.
Yeah,
as
I'm
far as,
grateful. Yeah, I appreciate that. And actually, it's prompted me to think that even though I was already given marching orders to do, I basically brought up that there was a lack of standardized materials for us to use in our education of our diabetes patients with regards to just diabetes education across the spectrum, and not just lifestyle and not just medication, but we're talking about, the whole managing sick care during when you're sick and when to go to the doctor and all those points. But how do we do it in a standardized way that will be well received and understood by the patient? And so like I say, I've gotten the direction and the encouragement to do it, but yeah, it's quite different from doing something face to face in the hospital with patients versus, in this, the way we deal with them most often nowadays, which is virtually. So, and we don't really have tons of, we try to enroll everybody in my chart. That's our patient. That's our portal. That's our virtual communication piece. But a lot of people, and we don't really even have the means to send information to them. And a lot of them don't have printers. So then what?
Yeah. And I think also, it's hard to have standardized resources because every community is different. And so I think maybe certain messages, but even within messages, I think, every community receives messages differently and, is coming at diabetes from a different perspective. And so I think being mindful of that, I think it may not be possible to really have standardized materials. If you're a large health center and you serve a lot of different populations.
Yes, and I think maybe to clarify, I mean more key points that need to be communicated, not so much, and it's certainly individualizing it to the population, to the, to the culture, with the food, with the, in terms of, their social determinants of health challenges. All of that. Yeah. But
I think,
thank you.
Yeah, thank you, Wendy. I think part of and I agree with, there's the standardized kind of language, but I mean, it's a balance, right? But I think, I don't know if you guys picked up when Art was talking about having the being confused by the information that he was getting because so many people were saying different things. And I
Mhm.
think that's where standardization of messaging is
Yes.
very important.
Uh-huh.
You'll have the registered dietitian saying something, and then you'll have the nurse saying something else, and then you have someone else saying. So standardizing what are these
Mhm.
the points and who is delivering that message, right?
Mhm.
That someone is not saying, oh, no sugar. And the other one said, yeah, you can have a little sugar.
Right.
And yeah, I mean, so there's a lot of mixed messages where people will say, I'm not doing any of it because I don't know what to do.
Right. Well, see, and that's the beauty of, at least that's that is a positive that we have, is that a comprehensive diabetes manual has been created by our organization, by one of the lead diabetes educators. And that's been approved across the board. So a lot
That's
of
good.
the content we can really, balance, use to, um, as a guideline for the
Mhm.
materials, but of course we're going to
Right,
pare it down. We're going to figure
right.
out how to break it out so it can be best presented and not overwhelm the patient.
Yes.
Hmm. Well, thank you.
I'm doing a little bit of like popping things in the chat.
Oh, that's great.
These are
Yeah.
just things that I've been like, as we're talking, kind of doing a little bit of Google, particular word searches and things. So they're not vetted. I haven't familiarized myself with these at all.
Hmm.
But the second one, I think might have some potential. And if they're horrible, my apologies, because I didn't explore these particularly for this moment. I just am
Well,
doing a preliminary search.
some of our materials we've actually pulled from this for that diabetes manual that we have. The one that every patient that gets discharged from the hospital will get the manual that has, it's not only type 1, but it's type 2 as well. But yeah, but what you've said has prompted me to really consult further with the diabetes educators and get their help and their input on developing something that, because they have to do it the same way that we do. They're doing it all remotely as well. So, but we're going to take it down. We're going to really scale it down to, simplify, make it the message much more concise, and for that we can do more on the fly, not like they're going to do they will do a whole session on nothing but that. So, but thank you. I do have to say one more quick thing is one of your recent learning collaboratives actually prompted me to respond to a patient differently. And it was regarding my bias with pain, I realized, with pain patients, chronic pain, long-term opiates and things like that. And I realized I had my own bias about that. And I had to really step back and realize I needed to listen to her. I mean, really listen to her. And it actually, the outcome was good because it prompted me to then schedule an appointment with her PCP just to talk. I mean, just because she didn't feel heard. She just really didn't feel heard by her PCP and just felt like she was continually being pawned off to the specialist, and not, she was looking for that warm, fuzzy connection with her doctor. And because a lot of her pain was also psychological
Yeah.
and
Emotional pain. I was going
emotional.
to say, yeah,
Yeah. Mm-hmm.
that's part of it too.
Yeah. So, but thanks. I mean, it actually changed my practice. I feel like I'm empathetic, but
Right.
but that's what the patient needed. So,
Right. Yeah.
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 Mm-hmm.
Thank you for sharing, Wendy. Really
You're
appreciate
welcome.
it.
Yeah,
Mm-hmm.
thank you. Yeah, it's a pretty powerful moment, I think, when a person feels listened to, and they not only feel that whatever they have to say is worth, the worth the time and the effort to be heard and listened to. But what often can be reflected back is that this is a partnership that they're engaging in. It's not just that they're the recipient of like the diagnoses, the care plan, and that they have to shoulder all this, but their word and their perspective has value in that as well. So, and building that trust takes time. And the first step, I think, is just listening and acknowledging that, you know, they're the most important part of this puzzle towards healing. And it's complicated. And as much as, you know, I hear you say trying to standardize these approaches, it's so important in a busy care setting to try to make standardizations, and we can work through our workflows. And sometimes it doesn't really, that's not the key, you know, it's really stopping and looking at this person as an individual with very different needs from other people. And that's wonderful. It's really, really wonderful. Thanks, Wendy. I think we can go, maybe unless there's other things folks would like to share, we can go on to the next slide. And Darlene, if you'd like to lead us through this next discussion, then I'll pass it over to you.
Great, thank you, Jillian. So now we're going to get a chance to have you, those of you who are on the call today, work on an action plan. Just as an overview, you know, we're going to be looking at how do we create something that is smart, a SMART goal. And so, of course, when we talk about SMART, we go with the S, which is specific, just what do you want to do? So that's very important, starting with the what. What is it that we want to focus on? The next is M, measurable. How will we know that it's been reached? How is it measured within a certain time frame or a certain number of people? That type of thing is measurable. And then achievable. Do we have the power to accomplish it? So if something is costing $1 million, that was not going to be achievable, but we want to make sure that we are looking at not only resources, financial resources, human resources, but just the ability to be able to achieve whatever we are setting out to do. Then is it realistic? Can we do this with, you know, in a realistic manner to achieve what we are proposing to do? And then T is timely. When exactly do we want to have accomplished it? So we're going to start, in the time that we have available, we're going to focus on some of these SMART goals when it comes to developing an action plan. So next slide, please. So now, creating an action plan, our goal is to help you apply what you've learned in this learning collaborative. And even, you know, during the conversations we just had, I learned so much. I just really appreciate when we do have the opportunity to share with one another. The steps we're going to take is, first of all, identify what you want to implement at your organization, and then create a success plan using the SMART goals that we just talked about. And I know just within the time that we have left, we have about 15 minutes left. So we may want to adjust our time some of how we want to guide these conversations. And then talk about how to get leadership buy-in and support, create a budget if necessary, then discuss and assign roles to assure clarity, conduct training, and then implement. So we may just want to do, we can't do all these. So probably just focus on the steps. This is just the steps of creating an action plan. We won't be able to get through all this today. Probably just maybe steps 1 and 2 within the time that we're having. So how does everyone feel about that? Do we think we'll be able to at least talk about 1, maybe 2 possibly within the time that we have left?
Yeah, I think you're right, Darlene.
Mhm.
Yeah. Okay.
Yeah.
So yeah, you guys, okay, so let's do that. Next slide then. I think we're gonna break out the rooms and go
And
ahead.
these are
Alexis, I think you're
Mhm.
gonna lead us through this.
Yep. So, so we're going to go into breakout rooms. We'll have about 5 minutes, given the time. And, these are just some guiding questions to help you kind of think about, the action plan. And with that, I think we have concluded the Learning Collaborative. Thank you so much, all of you, for participating over these past 4 weeks. And of course, thank you to my colleagues at National Healthcare for the Homeless Council and National Nurse-Led Care Consortium. This was truly a team effort. And so we very much appreciate everyone being active participants and sharing your best practices and sharing your strategies. And we will be following up in a few months to check in and see how things are going. But in the meantime, of course, please contact any of us with any questions or for more information. And otherwise, have a great rest of the day. Thank you so much. And thank you again for joining us.